report on our recent results on hematopoietic stem cell therapy in adulthood cerebral ALD. So first of all, I should probably explain what does it mean, allogeneic hematopoietic stem cell therapy. And you see here that first you need, for initiating such a treatment, you need a stem cell donor, which is sometimes very difficult to get a proper donor. And this may also be a major outcome parameter if you have a good donor versus a not so good donor. So this is one of the first important questions that you would have. Second, the treatment has to be started with a very invasive therapy. You need a chemotherapy which will destroy all blood-forming cells before you get the new cells transplanted. And this is a very critical situation in which a lot of problems may come up and complications may come up. So this is not a treatment that is very easy. It's a very complicated treatment and a lot of complications in this special situation where your own blood needs to be destroyed completely before you get a new blood. And then finally, you receive the new stem cells, which then will hopefully stop the disease. So this is the procedure that takes a couple of weeks until the whole process is done. So this is a very difficult and severely affecting life, quality of life, affecting therapy, potentially at least, which needs to be considered when you are thinking of having such a treatment in a certain situation. So this is important to say. The second thing I want to say is that you may know that there are different phenotypes or how the disease looks like in adulthood. Most of the patients do have the adrenomyeloneuropathy type of adrenoleukodystrophy. So this is a spinal cord and peripheral nerve system disease, and it's not affecting the brain. But in this situation, we are not considering a bone marrow transplantation or hematopoietic stem cell transplantation. This treatment is only reserved for the inflammatory phenotypes of the disease, which may occur, as you have already heard, in childhood cerebral ALD. So let's say around 1/3 of all males who have the gene defect will get this childhood cerebral ALD, but then 2/3 progress with AMN to adulthood. And there may be two situations in adulthood. The first situation may be that without any other symptoms, the cerebral involvement may occur spontaneously as the primary signs or symptom of adrenoleukodystrophy. This is very similar to what we see in childhood cerebral ALD. This also may occur in adulthood, but only on a rare occasions. It may be 2 to 3, maybe 4 or 5%. I don't know exactly because there's no data on this. But the more frequent situation is that that adults progress with AMN for, let's say, 10 or 15 or 20 years, and then suddenly they get the cerebral involvement. They get cerebral inflammatory involvement. So this is secondary to AMN, which can precede the whole situation even for decades. And it's not quite clear how frequent this really occurs in adulthood. But my personal impression is, and from the data that we have, that at least, I would say, 50% of all adults will get eventually the cerebral involvement during adulthood. So it's not infrequent that this situation may occur also in adulthood. And this is very important for all people who are affected with this disease, because this is a very good reason to have sequentially investigations every year to detect this cerebral involvement as early as possible. And after the talk, I think you will understand why I'm saying this. So what happens is that this, the spastic paraparesis, the myelopathy, the chronic progressive AMN version may convert in at least 50% of the patients in a period of 10 years of time to a cerebral involvement, which is then life-threatening. And this is a situation where we need to do something. Otherwise, the disease will really progress with a very bad prognosis. So you already heard about childhood cerebral ALD, and that there is clearly a survival advantage of children with cerebral involvement, with early cerebral involvement, in terms of a long-term survival. And you see here curves, two curves, which show you the difference between those who are transplanted versus those who are not transplanted. So in the blue curve, you see that there is a little step down right in the beginning, which is something which is associated with the risk, the early risk of a transplantation, but then the curve is going stable, so 95% has a probability for long-term good survival after transplantation in childhood cerebral ALD, versus those in red who are not transplanted. So maybe before I step further, I should explain a little bit on these survival curves. So let me explain it in this way. So if you have 10 biscuits, yeah, and you eat a biscuit, then something, and the biscuit is the end point, what you're looking at. How much biscuits do we have? So over the day, you eat all the biscuits, and then every time you eat a biscuit, the curve is going down. And the end of the day, you have no biscuits over. So these curves gives you an impression whether an event, let's say onset of a symptom, or vanishing of a biscuit, or death happens or not, and time and also it gives you some impression how quick this happens over the time. So you see a time curve on the one side, and you see the event happening on the other side. So these curves also, we're using this, I'm explaining this to you because I show you more of these curves in the next slide, so you should understand what I'm saying with these slides. You can also use these curves in comparing some situations. For example, you see here that obviously the fig rolls are much quicker eaten than the custard creams and the chocolate cookies. So you can compare certain events, eating a biscuit of different kinds. So you can also compare different therapies or different situations, treated or not treated, with these curves, like in the previous slide I showed you. So this is a good way to show how a treatment is really working. So, and look again at these curves here. The question is not only what is somebody surviving from a treatment, yeah, but it's also the question how he is surviving from a treatment. So how is his cognitive status, how is his quality of life, and what are the conditions that will determine the outcome of my specific treatment. So, and this are examples from our experience in childhood ALD treatment with bone marrow transplantation. And you can see here that there are certain conditions that gives you a better outcome than others. And this is very important for our decision if somebody is feasible for treatment, for stem cell treatment, yes or no. For example, if you have an unfavorable MRI, let's say very much changes already in the MRI, this gives you a worse outcome. So if somebody has a cerebellar involvement, that gives you a worse outcome. So it's very important before we decide, not only in childhood, but also in adulthood, if somebody is really will have a benefit from this treatment, we need to have very intensive look at the special situation in each individual case. I think this is an important message I wanted to give you. So our question a couple of years ago was, do adults also have the same survival advantage from this stem cell treatment? And this is the first series of 14 patients showing you a long-term survival of about 60% of the patients after this treatment in the situation when an adult cerebral involvement occurs. So 60% will survive long-term. This was the first longer or greater group of patients, and it's an international cooperation between French patients. One patient from the UK is in there, and the other patients are German patients. But on the other hand side, what we could see in this first study is that this treatment really can be life-saving. And this was the first time that we really show, because that this treatment, even in adulthood, may be life-saving under certain conditions. So we still have to look more closely, what conditions are this? Is it age? Is it low neurological symptoms at the time of the transplantation? Is it whether the patients have already bladder dysfunction, yes or no? How is the MRI severity influencing the outcome of the patients? Is there a donor quality difference? For example, using bone marrow or using cord bloods, is this a difference, for example? Do the patients still have, how's the family organized? Is there family care? How's the post-transplant situation? How is the psychological situations? All these are questions in detail that are very important to decide if somebody is really will benefit from this treatment. So, and finally, we also did not know at that point of time, this a couple of years ago, how is the long-term disability in these patients. We didn't know actually. So up to then, there are only some single reports on stem cell therapy in adulthood cerebral ALD. Most of these patients were treated in very advanced stage of the disease, and most of these people really did not benefit from this treatment. But here we show for the first time that at least 60% will benefit in any way. So in the meantime, we had a learning curve, so we are getting better with this treatment. And what you can see here is the recent results from 19 patients from one center, just from our centers, and you see survival curves are much better. So 80% is 0.8, 80% are long-term surviving this treatment. And this is, we can say this even after the first year already. But then there's still some cognitive progression in the second year, and after the second year, at least 50% are cognitively completely stable after this treatment. And even an event-free survival is judged after 3 years. So about 40–45% are completely event-free after this treatment. These are very promising data compared to the situation without treatment, where we know that at least 95% will die within 1 to 3 years. But even if you look closer at the data, it's only little data, I must say, but if you look closer at the data and look, for example, compare a group of patients who had very minor symptoms, who are fully ambulant, without any walking or little walking disability, and without cognitive deficits, and compare this to a group of patients who do have already severe walking disabilities and some cognitive deficits, you see tremendous differences. So patients who are at early stages, who are fully ambulant, without any severe cognitive deficits, have a 100% survival rate in our group, have a completely cognitive stable, over long-term cognitive stable, and completely event-free survival. So it depends on what time you transplant these patients. It's very important to look at these patients more closely. So I would summarize, of course, we need to confirm the diagnosis. This is clear, and we can only patients with gadolinium-positive cerebral involvement are feasible for transplantation, no AMN patients. So, in favorable conditions with a high likelihood of a beneficial long-term outcome are patients with mild or moderate symptoms, motor symptoms, mild or moderate cognitive dysfunctions, mild or no bladder or bowel dysfunction, and let's say a favorable MRI pattern, which is the classical Pareto-occipital pattern versus a more frontal or brainstem pattern. Of course, there are also some transplant factors, which I'm not going into detail because I'm not a transplanter, I'm a neurologist. I'm looking for the long-term neurology outcome. But what seems to be important is that you have a matched, most likely related donor. In these situations, I personally recognize there is very low graft versus host or rejection of the graft, and there's very low organ toxicity, but maybe Troy can say more about this in the discussion, and we have little infections. So this is versus the situation where we have non-favorable conditions with a low likelihood of a beneficial long-term outcome. This is in patients with already severe motor symptoms, with severe cognitive dysfunctions, with bladder dysfunction, with bowel dysfunctions, and severe MRI brain changes. And of course, if the donor situation is not so good. So, in summary, I would say that stem cell therapy is currently the only, in adulthood cerebral ALD, the only life-saving and therapeutic option. We can show that the inflammation, that the brain inflammation is stopped in nearly all patients. The treatment has really problems, severe problems, but there is low graft versus host disease in most of the patients. But it's absolutely important to have a careful pre-selection of feasible patients. So this is very important. Of course, there is still a need for more information and a need for an international exchange of these experiences. I think this is very important to get more information and to discuss this procedure more closely with a larger group of patients. And of course, there is really a need of an early detection of this brain inflammation. So I still urge you to have very close, at least 1 year follow-up investigations with MRI and neurological investigations. And of course, this is a very good reason for newborn screening as well. So finally, I will thank the people from my group, but also cooperation, especially for the transplanters in our group, the pediatric transplantators, Jörn Kühl, and the adult transplantators led by Georg Franke, and international cooperators, and of course the sponsors for this treatment. Thank you very much.